Good afternoon. At the outset, I would like to really thank you all. Although the course starts at 11:30, we are starting a little earlier. We have another 2 minutes to go. But I would like to sincerely thank you for this, making it a point to come and attend this course. When you have multiple halls with very excellent sessions going on, for you to really especially find time to search for this hall, because even I had to literally search for this hall to come here and be here with you. And we are also very privileged today that we have none other than Dr. Harminder Dua giving a keynote address. So, sir, we are very privileged. If you are comfortable, you can be with us on the dais. That will add more glory to the dais. And we have, excellent battery of speakers. This course, all of us do cataracts, all of us try to do good surgeries, but sometimes, some way through the middle of the surgery, we change the course because things don't happen as we wanted, and suddenly we have to take that decision on the spot. Now, this thinking on your feet is a session where we would like to see how the top surgeons, skilled surgeons, suddenly don't go by the fixed plan, and they suddenly are required to change the course and then finally either get good results or not so good results. So this is a course where we have requested all the panelists to come together and put forth this course. And with that, our first speaker, Dr. Anaga Herur, a very prolific surgeon from Bombay. Of course, all of us know her because she's at a national level today, managing everything and the practice, and to be a skillful surgeon is also something that really asks for too much. And we have Dr. Anaga speaking to us. Anaga, it's all yours.
Thank you. Thank you so much, sir, for giving me this opportunity to speak in your IC. And regards to Dr. Dua, sir, and to all our star speakers. So a very good morning to all of you. And today I'd be presenting a few cases which I thought were interesting. So I'd move on to my first case. So this is a routine cataract surgery. It's a posterior subcapsular cataract, so a routine surgery. And I'd just take you through the steps. So phacoemulsification, a routine irrigation and aspiration. And now we are moving on to the IOL implantation. Now watch carefully. So this is a single piece hydrophobic acrylic lens. So I'm loading it onto the cartridge with some visco in it and then taking care to see that both the haptics are in place. And I'm now injecting the IOL into the capsular bag. And now watch carefully what happens. The trailing haptic has got now stuck into the injector. So I am trying to dislodge it from both the sides, but it's like, it's not just the tip of the haptic, it's the entire, from the optic haptic junction to the entire haptic. So I would stop here to ask our panelists also, what would you do at this point of time? So I'm trying to open it, but now the optic has completely opened up. And it's not that it was just in the cartridge, otherwise I could have just retracted it. The entire optic has opened up, and now this is the situation. So unfortunately, at this point of time, as I was trying to maneuver, there is a slight decimates detachment also, so I had no option but to extend the incision and then completely remove the IOL along with the stuck cartridge, and then we put in another intraocular lens. So the next time I thought maybe it's the haptic which had got stuck into that blue silicone sleeve. So now this is the next case that I'm doing. So now in all these cases, I think it's so important not to be in a hurry. Really see to it that both the haptics are, sometimes it comes back because of the memory. So I'm trying to push it 2-3 times, and until you're sure that it is very well very closely kept towards the optic. And then as you push it also, just see to it that it's not, the trailing haptic is not stuck in the blue sleeve. And then now each time I put in a hydrophobic single piece acrylic lens, I'm just, very careful to observe whether the haptic is coming out right or not. So this was another case. It's a preoperative picture of a phacomorphic glaucoma. So this was a 65-year-old gentleman who came to us with a vision of perception projection of light and an IOP of 50, which has been there since the last almost 3 weeks. And when we did an OCT of this patient, you can see that there is absolutely no anterior chamber at all. It's totally obliterated. It was an intumescent cataract, and the pressures were very high, corneal edema. So the challenges were a small pupil with posterior synechiae and very high IOP. In spite of mannitol, the IOP was still high. So we did a port, and that helped to reduce the IOP. And then it was also important to form the anterior chamber. So we pushed in viscoelastic, formed the anterior chamber, also released the posterior synechiae, but pupil remained the same. So now we had to stain the anterior capsule also, plus put in a pupillary expanding device, because remember it was an intumescent cataract. And there was a lot of pigment dispersion also on the corneal endothelium also, as you can see. So we're putting in retractors, but at this point of time, I found that the pressure was rising again. So one take-home message, what mistake I did was, we had removed the port, thinking that now that the IOP was normal, it would stay low, but the pressure shot up again. So this passive vitreous decompression, you can see the drop at the tip of that port. So that passive decompression helped to keep the IOP low. People also advocate going and doing a small amount of vitrectomy. Also, we didn't need to do that as the IOP remained low. Now, the second challenge was to do a good capsulorhexis. Fortunately, it didn't run out because of the good use of high molecular weight viscoelastics. And because it was not a very hard cataract, it was fairly easy to do the phacoemulsification and the cortex aspiration. But as I was putting in the lens, I found that the entire bag was a little wobbly. So I didn't want to take a chance, so I thought it's safer to put in also a CTR. So now in goes a CTR also for better capsular bag stability. And it's always important to stabilize the CTR with the second instrument so that the tip, the edge, the last tip also goes into the capsular bag. So now it's time to remove the iris hooks, and then I'll be putting in a little bit of diluted tricot to check whether there's any vitreous, and then that ends the case. So this was the second day post-op, 14 days post-op. In fact, the IOP rose up again. We also did a surgical iridectomy, but he had to be subjected to a valve procedure later. Third case is a patient who had been operated for a phakic IOL for a very high myopia, almost 18 diopters, in 2014, and she came to me almost 6-7 years later with a nuclear cataract. Now in these patients, because it's an optically clear medium, an optical biometry gives us a fairly good IOL power result. Now this patient wanted flax. Now in patients with prior phakic IOL, when you're doing flax, we need to make certain changes in the settings. So I've increased the pulse energy also of the capsulotomy. The important point to note is the OCT considers the phakic IOL as the anterior lens capsule. So you need to manually shift those 3 dots there down. As you can see, otherwise it would have fired onto the phakic IOL itself. So you need to manually make those changes, and only then you would get a proper capsulotomy. Also, the pupillary edge is not very clearly delineated, so that also needs to be manually properly made. And once that is done, the capsulotomy and the nuclear fragmentation is done. Now, one more take-home message is this was an IPCL, which is slightly thicker and more rigid compared to the ICL. So If it was an ICL, probably I would have removed it before and then gone ahead and done cataract surgery. But here I thought maybe I would have to extend the incision. And if I try to pull it out through a 2.8 millimeter incision, it could have damaged the incision or the wound. So what I did was I was sitting temporally, I rotated it vertically, and now I am doing the phacoemulsification from underneath the IPCL. But note what happens as I'm doing the phaco, there is a radial tear in the anterior capsulotomy. So which means that doing a flax in these cases does not necessarily mean that you get a complete capsulotomy. It's a postage stamp perforation, but you need to be extremely careful. And in these cases, a very high myopia, one diopter lens with a radial anterior tear in the capsule, you need to be really very careful to see that there is no sudden shallowing of the anterior chamber. At the end of the day, patient did well and vision was 6/6. So this paper mentions how the laser beam that is deflected by the optic of the phacocoil and the gas between the anterior capsule and phacocoil actually induces radial forces, and this is a known fact. So we need to be extremely careful in these cases. This was the patient post-op. So I would like to end with one of these cases. This was a patient, a one-eyed patient, one eye lost due to a traumatic RD, and the other eye was a very high myope, 18 cut RK done, and then LASIK again done few years later. So you can see multiple cuts of RKs plus the metallic deposits in the interface. This is the OCT picture. This was the topography, a fairly good myopic ablation in the center, but a lot of keratometric variability on the EKR report. The dilemma was that whether to take in the post-RK IOL formula or to use the post-LASIK formula. So you can see post-RK, it is showing a 21 diopters on the Barrett 2K, whereas the post-LASIK, the Barrett 2K is showing 23 and the Higgs L is showing 27. So even on the ASCRS online calculator, on the post-LASIK, we did two readings. It was showing around 24 with a maximum of 25, 26. But as a post-RK, it was showing 20 with a maximum of 21. So we went ahead with a 25 diopter lens, and again this patient wanted a flax procedure. So because of the few metallic deposits in the cornea and the interface, sometimes that could cause a problem in the femto laser. But fortunately, the patient did well. So is my time up? Yeah, so this is just ending the case. So this was a free-floating capsulotomy and the phacoemulsification. In RK, you need to be very careful to have a slightly posterior limbal or a scleral incision so that the cuts don't open up. And this was a one-eyed patient. We put in a single-piece hydrophilic, and thankfully, the patient was good post-op. So I'd like to end here. So this was just a post-RK case. Yeah, thank you so much for your kind attention. Thank you.
Dr. Anaga, for a variety of cases, different situations in post-refractive situations where you have to make those changes. With regards to that, phakic lens, and when you do, I mean, your concern was that maybe you'll require to enlarge the opening to take it out.
Yes, so take-home messages we don't need to enlarge.
Yeah.
So finally, I could bring it out through a 2.8 millimeter incision. So I'd like you all to take home that message so that you don't need to make the same, go through it again. So I could easily remove it with a hand-on-hand technique through a 2.8. So even with the rigid IPCL.
Yeah, because contrary to what we do today, for every cataract we are looking at 2.2 or 2.4. But there was a time when all of us did phaco through 2.8. And 2.88 is also a good incision to do, provided you just remember the amount of extra astigmatism that you cause, which is not really much. So in these cases, if you have to switch from 2.4 to 2.8 doesn't really matter. But you only have to remember that your settings need to be slightly tuned up for 2.8, because when you are at 2.8, you may have to tone down on your vacuum and aspiration flow rate. Yeah, Thank you so much, Anaga.
Thank you so
Yeah,
much,
please.
sir.
I just wanted to make a comment on your first case. When you're dealing with lenses that are not preloaded, when you put the lens in the cartridge and you clip it and you put the plunger in, it's always good to check the movement of the lens, because sometimes the haptic gets caught in the cartridge and you come out with a broken haptic with only one haptic at the other end.
Right.
And if the plunger is going ahead of the back haptic, you know you've got it wrong. And it should always, so we do that check, and because you do so many, you think you take it for granted, and it should move into the nozzle freely.
In fact, I now push it and then wait as the plunger retracts. You see whether there is any attachment to it or not. So that's the take-home message. That check that under the microscope and only then go ahead and implant.
But could you have tried to just pull the plunger out by holding
I tried it, sir.
It didn't come.
It didn't, because as I was doing that, I created a very small DMD also.
Okay.
So I thought it's better just to open it. I would just like to know what different, how differently anybody of you would have managed that case.
I mean, once it's stuck, it's stuck. So you have to take it out.
Was there a way to remove it without extending the incision?
I mean, only one hour, like I said, I suggested you would have tried to pull the plunger holding
I
it.
did that,
And
sir.
if it didn't come out,
didn't.
then you have to remove it. Yeah.
Ma'am, once I've tried to cut with the sharp keratome, just to cut the bevel of the
But it
injector.
was already
all the way.
inside.
Yeah,
inside.
and
It
then
was
that
not
kind of opens up, maybe then the plunger may
Yeah.
have come back.
This was
it's worked
already
in one
inside the
case.
wound.
True. It was a tough one to get out.
Anyway, thank you so much, sir.
Thank you, Anaga. And now we go to the next talk, Dr. Tanvi, excellent phaco refractive surgeon who's come into my practice as a, as a great gift, and she has, excellent cases to show you as always. So I wish you all the best, Dr. Tanvi.
Thank you. So today, the topic is think on your feet. There are some surgical steps you may want to change while you're doing it. And today I'm going to discuss two cases. One which I had to intervene and manage, and the second which I had to do it myself and think in a different way as to how would I do it other than my routine phaco surgery. So the first case, I've titled it as Too Fast, Too Furious, when speed in phaco becomes an enemy. Today I think there is this general feeling that if I do a good phaco, that means I have to be a fast surgeon. I have to operate in so many certain 7 minutes, 8 minutes, or whatever. I think the speed or the amount of time you take to do surgery rather than what actually comes out as an outcome, that we need to reconsider what's important. Now this is a surgeon who's wanting to finish the case quickly. Each step has just gone on from one to the other without really making sure each step has gone well. Hydrodissection wasn't complete. He's still gone ahead and tried to rotate the nucleus. There wasn't a wave, so you can obviously see there's a lot of zonular stress that he's landing up doing, and then filling a lot of viscoelastic before every step. Now he's gone inside with the bevel down phaco, done a little bit of cortical aspiration, the loose cortex has been taken up, and without removing or using the other hand to sort of stabilize the phaco probe, he's also trying to rotate it so that he can start his nucleus management. At this point itself, you can see that things are quite turbulent. And then when the phaco starts, obviously the irrigation, aspiration flow rate is very high, the powers are high, the vacuums are high, and all of that is causing too much turbulence, and already you can see the iris has started coming down. Now at this stage also there is a chance for you to slow down, take a breather, and then do something different. But of course, we kind of become like Arjuna, and we are only looking at the tip, maybe just the nucleus, and the rest of the tissue, how is it coming out, is it staying stable, all of that just goes out of our minds. And here again, there is a lot more viscoelastic being put in, because obviously the iris is also wanting to come out. But the primary error that was happening is that he had already filled the anterior chamber a lot and then filling it more with viscoelastic, hoping that that iris stays inside. So now that iris had had enough. He was just being poked and poked and poked, and it refused to stay inside. So this is the time when we need to understand what is it that you can do. So first, you need to stop, take a breather, literally for 10 seconds, take a breath in, breath out, and then realize that why is it that this is happening. So in this case, the incision was very shallow. It was not a well-constructed wound. So the iris, after many manipulations, had already started coming out. So now what I did was I set the iris back in its place, use a high volume viscoelastic. You can either do this from the side port. It is better to do it from a different incision than the main from which the iris has been coming out. And now obviously the plan was to complete the case. Since I wasn't the primary surgeon, I didn't know where the rexus is, how large it is. So when there are these uncharted paths to cross, it is always better to do something which is going to give you good visualization and which will help take your path easier. So we put a pupil dilating device. You could use the B-hex. It's an excellent tool to use. This is the B-hex forceps, which can help guide the B-hex ring under the iris. All of this has been done under high molecular weight viscoelastic. You can use a spatula, you can even use a dialer to just sort of get the iris away. And then always stay in the capsule. Many times surgeons feel that, oh, already there's viscoelastic inside. Do I really have any advantage of using that stain again? But there is. Whatever little it'll stain, you will still have a better guide to understanding where the rexus margin is and where you are supposed to work, where is your safe zone of working. And then, of course, make a new side, main incision, because that's what is going to take you from the end right till from the beginning right till the end. And here, I think the way we keep the phaco parameters are extreme importance. You have to keep the flow rate slightly less. Here I'm using the burst mode to do the chopping, so it's an 80-20 on-off time. The power is just as much as I need, nothing more, nothing less, depending on the grade of your nucleus. And direct chop probably becomes a safer approach rather than sculpting, because then you're going to cause less zonular stress. And by just doing this in that safe zone, you can see that the phaco probe does not move really to the periphery. It is staying right in the central 2 millimeters, 3 millimeters of a diameter of a circle, and therefore you can very safely keep the iris at bay. Another thing that I want to emphasize is where the irrigation ports of your phaco sleeve are. So once you're inside, make sure that the phaco sleeves irrigation ports are right in the center and they're not again hydrating the iris to get it out. And very safely, as you can see, the lens has gone inside and the B-hex is removed. And something which was chaos could very easily become a clear and a good post-operative outcome. So just a few steps and things I would like you to understand from this case is that you need to know there can be an iris prolapse anytime during a routine phaco surgery, and there are certain pre-existing risk factors which our patient may have, but there are a lot more surgical steps that you may do differently that can cause this. So in our case, what had happened is that there was a sudden increased pressure gradient. There was a lot more viscoelastic that was inside. When the phaco started, the parameters were wrong. The wound integrity wasn't so good. The architecture of it was not composed very well. It was shallow. So all of this caused that iris to come out. So what can you do? You need to reduce that turbulence. Maybe you may even decompress the viscoelastic a little bit initially from your main wound. Make sure it's just the optimal amount that you need. Use high molecular weight viscoelastic. Use pupil expansion devices. Stay in the capsule. Visualize it better. And then reposit that. So while you reposit the iris, also make sure you're not doing it too hard, because then you could cause a dialysis. And then use a separate, there's no harm in creating another 2.4 millimeter main incision. It's a clear corneal incision with a very low astigmatism inducing incision. You can always make another one right next to the one that is failed. So the take home points would be that do a good preoperative planning, and then of course if things don't go your way, do a better wound construction, control your fluidics, and I'm sure it will go well. So the next video that I'm going to show is of our own case, which is taming the storm. Now here was a patient who came with a phacolytic cataract. You can't see anything. The pressures were very high. There was already a leakage of the protein material out into the anterior chamber. We had controlled his pressures, but he obviously needed a surgery. And under mannitol, under getting the pressures as low as we could, we've started the surgery. So again, mind you, this is a case where you don't know what's under that lytic material. You can't see anything. So you are going to have to think on your feet as to what's next. So as you can see, when you decompress it with a side port, most of the lysed protein material is out. Then we have injected a high molecular weight viscoelastic, because now you need to do manipulations to go in, make the rexus, and then to deal with the hard nucleus. We can very well see it's almost grade 4, grade 5 nucleus, where most of the loose liquefied cortex is already out. So all the bag has is that hard cataract. So here it is important to go with that irrigating cannula and then to just wash that thick fibrinous material, mostly which is stuck into the anterior, into the angles and then causing that glaucoma. So it's a good idea to spend a little extra time to just wash it. And then you set that lens back complex slightly back with a high molecular weight viscoelastic. And as you know that this lens is going to take a little longer than a normal phaco to operate, it would be a good idea to just extend that space and visualization. So here we are using 2 Y hooks to open up the pupil, but then also a good idea to put a B-hex ring because it will help you in the later stages of nuclear management. And with the newer B-hex ring that has come up, you do get a larger visualization, more than what it was before. So this is what we do. And then you have to start thinking of how is it that I'm going to tackle the anterior capsule. And as you can see, it is a bit fibrotic. And you know that inside there isn't going to be any sort of a feedback because most of the cortex is out and there's very little mostly present inside. So once you take a nick with a 26 gauge sharp needle, because that's how you're going to be able to cut, put a high molecular viscoelastic inside the bag. That's probably going to help you manipulate the rexes better. And then a nice idea is to just use an external light source like the light pipe, because many times the contrast of that color of the capsule in the background of the hard brown nucleus, it's not very well. So this external light source really helps you navigate where the tearing margin is, and then you'll be able to do a much safer rexis. If you're planning to do with a cystitome, it might be a little difficult because there is nothing to push back underneath. You may have to re-inject a high molecular weight viscoelastic repeatedly, but that's also something you can do. And in the end, as you can see, when you do a hydro dissection, there is nothing to dissect because it's just this hard, phacomorphic or rather hard cataract which is right there with no liquefied cortex. So now when we do the nucleus management, we don't want the bag also to come around, and therefore to stabilize it, we decide to put a CTR ring, and this sort of helps expand the bag a bit. This step, you need to start thinking of how you're going to get your phacoparameters on because it's a hard cataract. You're also going to have to think of the endothelium, how much time you will spend in. Zonules need to be relaxed, not tortured too much. So the plan would be then to again do a direct chop. A vertical chopping mechanism is better. You could use the bevel down technique for a better capture. Once you hold the center, which is the thickest, you could either use a sharp chopper, but we have these blunt choppers which are slightly long and slender, and they work very well, and they're obviously safer. So by going a slow and steady approach, just keeping your cool, rotating as and when you want. So here again, we've used the burst mode with a lesser on time and more off time, but the power needs to be optimally balanced with vacuum. So the safest vacuum that you can work with, we've used around 550 and a flow rate of around 26 to 32, depending on how well versed you are with your foot pedal. This is what we use. And at the end, you can see that it is only the nucleus that has to be removed. And at the end of it, barely any cortex, but you can always do a bimanual, irrigation aspiration for a safer rather than a coaxial one. And then implant the lens, get the B-hex out, and the case is as routine as it could be. So the pathophysiology of these phacolytic glaucomas, we know that there is that leakage of lens protein which could cause flare cells and possibly fibrin formation, and we should anticipate that yes, intraoperatively there will be poor visibility, there may be zonular instability, and the capsule may behave differently than a normal one. So you need to be aware of these things and then plan. So the strategy would be to do a CCC, most probably with a capsule or excess forceps, because a cystitome may not be able to give you that kind of flexibility, and you should not anticipate much cortex. You will be wanting to use a CTR, so keep that in your OR in case of wanting to use it. For doing a phaco or a nuclear management, direct chop or a stop and chop if you're not well versed with direct chop, which just optimal low phaco energy and fluidics, you should reduce the turbulence, the nucleus cannot be moving all around. And then post-operatively, you need to manage this patient with intense steroids and NSAIDs, and then of course to manage the pressures with the help of your glaucoma colleague or giving them AGM. So with understanding what the cataract was, how it was, surgical planning can be done before, and we can definitely give them a good outcome. Thank you so much.
Thank you, Tanvi. Both the cases are very interesting. Now I want all youngsters who are into phaco to remember the first case highlights a point which is very, very common. You know, uh, hydrodissection, as simply put, although it's a very simple step to do, many of us, if I had some issues, we somehow kind of hesitate. And then when it comes to starting the case, we inject viscoelastic because the nucleus isn't rotating well, and we tend to inject viscoelastic sometimes little more than necessary. And once the iris starts coming out because of increased intraocular pressure, we forget that only that pressure can be brought down by going through the side port. That has been highlighted very well here. The more you try to push the iris back, it'll tend to keep coming repeatedly. Thank you, Tanvi. That point was very nicely brought out. And even in the second case, Dr. VC, you can definitely add if there's some point to be added. Those are the nuclei which are the hardest. So, in managing nucleus, will you have a different strategy when it comes to such nuclei where all the cortex is gone, only just the hard nucleus that is left?
Yeah, I think that's the challenge that you have to face, the hard nucleus, and bevel down, and a good chopper is a good strategy with a lot of viscoelastic in the bag. Behind the IOL, behind the nucleus also is a good idea. So keep on chopping and making smaller and smaller pieces, and keep on adding the viscoelastic from time to time to maintain the chamber and protect the endothelium.
Lovely. Thank you. Thank you, Tanvi.
Thank you.
And now we go to another maestro, Dr. Sandeep. Excellent surgeon, excellent approach to how cataract should be managed. I think we continue to learn from Sandeep. The finesse in cataract surgery is what we learn from him, and it's an opportunity for all of us sitting here. Sandeep, the stage is yours.
Yeah, so, this case was a challenge, basically emotionally and every little way, physically as well. So I thought I'd share it with you. This is a case which I did for the very first time. Dr. Dua sir is here, and he would know about these cases much more than I do, and I would like to take his guidance. So she was a 56-year-old lady who had been complaining of diminished vision or severe loss of vision in both eyes. She had history of repeated attacks of sclerouveitis in the past, and she was diagnosed as Wegener's granulomatosis, also now known as granulomatosis with polyangiitis. She was being treated with cyclophosphamide and 10 milligrams of Visolone. The rheumatologist who referred her to me said that she was okay, now well controlled. And what I saw on slit lamp was that she had bilateral complicated cataracts, posterior synechiae, and massive ciliary staphylomas with extensive scleral thinning. And there was absolutely no view of the fundus on OCT, and the only little thing that I could do was to get an ultrasound done, a B scan, which showed that she had massive vitritis in both eyes. So the case started from there. This is how the appearance was on slit lamp, just posterior synechiae and a little irregularly dilating pupil. But what was to follow was something much more. As you can see on the temporal side is large staphyloma, almost abutting the limbus, nothing there. This is the one on the nasal side, and this is the one superiorly. So she was from all quadrants. There was hardly any way to approach this eye. So I didn't know basically what I'm going to let myself into. Is this chamber going to stable? How will I attack, do it in case there is a problem? Is there some way I can go through the sclera? No, nothing. So we had to fashion a way to get it done. And so the first thing that we realized was that the vitritis was not absolutely well controlled. There was some chronic flare in her eye, so we sent her back to the rheumatologist and asked her to increase the dose of the prednisolone. So she put her on 60 milligrams oral prednisolone for 3 weeks and topical steroids 6 times a day to control her local disease. And no NSAIDs were used in the surgery either preoperatively or postoperatively. And of course, she was in a very close follow-up with the rheumatologist. So once ultimately I was convinced that the uveitis was controlled, the rheumatologist was happy the way the disease was being controlled, we decided to take her for surgery. And this is how it started, okay? So as you can see over here, this is how the case looked. I'm making the side port incisions now and filling the chamber with viscoelastic. There's no way to hold the eye, so just use a very sharp blade to enter the eyes. And the first thing we did was like what Tanvi did is separated the synechia and did the good old stretch pupilloplasty. The next thing what we did was fill the chamber, stained the capsule with trypan blue, and used a needle cystitome to make the capsular rhexis. Try to make it as large as possible because we knew this pupil would come down, and I'd be happy to get 4.5, 5 millimeter rhexis. Went under the pupil for some time, but was kind of managing with a huge amount of viscoelastic being put in the eye. The problem of this patient was there was a lot of hypotony when this was going on, but notice what will happen at that time. So far so good. So at this point of time, everything looked okay, and then I started the trenching process. And that's where my heart sank, because the moment I was going in, everything was leaking out, absolutely. I normally do a phaco with low parameters. So basically, I normally keep a pressure of about 20 to 30 millimeters of mercury. And here, I was finding that I was hardly getting space. Whatever visco I was putting in the eye was coming out. I didn't want to put a viscoat because a dispersive viscoelastic would have caused a wound burn. The helon was getting out of the eye, so I used the good old HPMC to form the chamber as much as possible. I had to raise the IOP setting to around 80 instead of the normal 30 to maintain some kind of a chamber over there. Because as you can see, all the fluid was leaking out from everywhere possible, okay? And if I am not seeing clearly, you are also not seeing clearly because there's so much of water. I've been using some suction to try to get the water out, okay? But somehow I managed to do a little stop and chop. And at this time, I got into another problem is that when I used the parameters, I had to use a very, very high vacuum. I used about 650 millimeters of vacuum with a flow rate of around 34 or 35. And I had to do completely bevel down because I was not able to get the thing. There was still quite a bit of nucleus in the posterior chamber, which I was trying to get. And then finally, I managed to get something there. So there was no classical chopping like you see. It was just like you have to get it out. And I wanted to try and finish the case as soon as possible. It took me almost 40 minutes to do this case. And it's, of course, an edited video. But somehow we managed to get that last piece in. And then, of course, as usual, whenever you see in these cases, you move the iris away, and there are always chunks of cortex hidden behind. And at last, I thought that we have done this thing, and now we're injecting the lens. See that staphyloма? I was so very scared. As you can see, all the viscoelastic comes out. Nothing stays in the eye. I was wondering how we are going to close this eye. So managed to put that in, finally. And got the last haptic into the eye. Did a viscoaspiration both in front as well as behind the oil. And then I, of course, hydrated the wounds, all of them. What I missed out here showing you all is that it was not staying, and I had to actually put a suture on the side ports, and that's how I managed to finish the case. Post-operatively, the patient had a lot of vitritis, and the vision, which was from PLPR, just moved to finger counting. She was once again on steroids. She was put on difluprinate eye drops every 1 hourly, and almost after a month, she recovered 6/18 and 18 vision. And this is what the OCT showed. Ultimately, when we were able to see that because of the constant vitritis, she had a massive epiretinal membrane, and I referred it to my retinal colleague. He said, where do I go in from? There's no pars plana to enter this patient's eye. And so we left her as it is. But of course, she's very happy with what she got, and I thought I'd share this with you. Thank you so much.
Beautiful, beautiful. Dr. Dua, would you like to say a few things?
Yeah, you did it very well, actually, despite what you said about the difficulties and your heart problems during the operation. But in such cases, it is not something to be ashamed of if you do small incision cataract or an extracapsular extraction. The less you manipulate, the better with regard to cystoid edema as well. Very important to check corneal sensations before you do the operation, because if it's a hypoesthetic cornea, the chances of melt of the wound or central melts, neurotrophic keratopathy, particularly in patients with these collagen vascular diseases or polyangiitis, is high. And you can get very intractable melts. And the right thing you did was give the preoperative high-dose steroid. You carry it on post-operatively and taper over 1 or 2 months very slowly so that you keep the inflammation under control. So those were just a few things that came to my mind during watching your case. But
I did think of small incision, but there's no sclera to actually make that. So it would have been either extracapsular or this. That's what. I just took a chance and I succeeded. I just did the other eye last week. We have had a better result over there. There she's recovered 6/9 partial vision.
What you did there differently?
Sorry?
In that other eye, what you did?
So other eye I did similar, but the other eye was better in terms of the uveitis, posterior uveitis. And though there was an epiretinal membrane there, not as bad as this one. But this was, so many days of thinking what to do, how to go and all those things. And then on the table, when you realize it looks all good. The moment you enter inside, it's a flat AC.
But what could be the reason for that? Was it the leakage or the fluid was just...
Fluid was getting out. I think, in these cases, the limbus is so thin. Even if you do a 1.2 incision or a 2.2, it kind of expands or increases. So there's leakage from all over. And plus, I think some fluid was getting misdirected posteriorly. Also, the speculum was keeping on pressing on those staphylomas, so there was shallowing all the time.
The sclera was barely there to give that
There was no
elasticity.
chamber, actually. So I had to keep it full with HPMC and not any of these two other, because the Helon just was flowing out, and I didn't want to try Viscoat because Viscoat will burn you'll have a corneal burn over there. And then just kept the IOP at 80 on the Centurion machine, and so I was able to get some.
No, but on the contrary, it's difficult for us to say it now. Now, since you say that a lot of it was leaking out, let's say if you had filled the periphery with Viscoat or higher molecular weight, and then with your usual low settings, played just in the center. Because your concern was the leakage. Leakage you could always avoid by injecting viscoelastic in the periphery.
You mean Viscoat?
Viscoat, which would block the openings, and in the center you are working with a low parameters.
Yeah, I would. I don't know when I'll get a chance again, but maybe I'll use.
But Dr. Dua, here other than going through the clear corner, there was no other scope.
There is no other scope, because what I thought you were going to show is that the staphylomas burst.
Thankfully not.
That would be, but one thing you might have considered is giving intravitreal steroids, because the epiretinal membrane is probably the main cause for the traction, but some surgical induced, inflammation-induced edema would also be there, which you could reduce the macular edema with a intravitreal triamcinolone injection.
The only thing is the pars plana was difficult to approach, because almost 360 degrees full staphylomas was all around, So that was the other issue.
At the end of the operation, you go through the anterior hyaloid.
I think yes, yeah.
Thank you, Sandeep.
Yeah, thank you, sir.
And now we come to another prolific surgeon who's been, we grew together. He's been the trendsetter. I always followed him. And he's an excellent surgeon. Dr. VC, it's my great pleasure to invite you to join this with your thinking on your feet.
Thank you, Suhas. Thank you for inviting me for this particular instruction course. I'm not going to talk about difficult cases. I'm going to talk about the day-to-day cases and how you get into trouble and how you can get out of it. Because that is equally very important, that you end the day with a good thing. So routine cases, non-routine complications. If you look at this particular case, it's absolutely a routine case, and it's proceeding very nicely with incisions and rexes and everything. And sometimes the complication hits you suddenly and wakes you up from your kind of routine thing. Now here you see the nucleus is out, and I formed the chamber with the saline before going into the chamber to do I and A, and then I have to change my hands. But unfortunately, this time I don't go into the chamber and I start doing the I and A from the other side. And as I take up the cortex and I realize that there is something wrong. I see tissues which are not supposed to see. If you see that, and then what has happened? In a slow motion, this is what has happened, which I saw after the surgery, that when I was putting the irrigation in a shallow chamber or a flat chamber, the descendant membrane detachment took place. So my first worry was that I should not aspirate the descendant membrane, detached descendant membrane. So I had to put in some viscoelastic below it in the chamber, and I have some amount of cortex to be aspirated, which I do it under the viscoelastic without disturbing the detached descendant membrane. And once that is done, then we have the issue of putting the IOL, and I thought that I'm going to put the IOL under saline and not under viscoelastic. So this is, I prepare the IOL, and under the saline, I put in the lens, and the lens has its own thoughts. The fetal position just didn't open up, and the lens, when it opened up under the saline, it opened upside down. So I already had one instrument inside. I put in the another instrument and flipped the lens and put it in the right orientation. Having done this, then you have the problem of putting the detached descendant membrane back into the place. And we put in a saline, a bubble, but we went through a clear cornea and put in a large bubble and hope that this would settle the matter. Next day, I asked my cornea specialist to have a look. He said there's a little bit of detachment still remaining, and he did an extra amount of air bubble injection. And fortunately for us, this patient settled down after about 4 weeks of time with about 2 or 3 air injections. So my point is that if you take a shortcut at some point of time in a routine case, you will be, you will get something which is very drastic and sight-threatening. So the lesson that I learned was always enter an inflated eye, never enter a deflated eye. So the second part is the pupil expanders, which is our answer to the small pupil cataract surgery. And if you see this particular case, very small pupil, repeated attacks of iridocyclitis, YAC-PI also done. So these cases have become so simple with the pupil expanding devices, and you can see one of them being done here. From a very small pupil, the pupil expands and makes your life very, very easy. The pupil expanding devices are easier to put in and easier to remove, and it changes the whole kind of management of this small pupil. Well, the point is you have to use some pupil expanding devices, whether it is iris hook, whether it is a Malyugin ring, whether it is a BVI Visitec ring, or a BHEX pupil expander, or a Gupta ring. Take your pick, but you use it, please. Because once you use this, it makes your life very, very simple. Mind you, when you begin to use these rings, there are nuances involved in the usage of all of these rings. So they all have their kind of tricks that are required to be learned to efficiently use these rings. And I learned it little hard way, and you can see here one of the videos where, I'm putting the ring in. Most of the time, the 3 rings, the 3 hooks get engaged, and it's only the 4th one that you have to put in with your side port incision instrument. And here, when you do this, the 4th one, instead of engaging the pupil border, it goes behind. Now, how do you remove this? Because this is a little bit of challenge. So what we do is we push the the one that is that you see, the other ring, not try to fish around in the unseen areas. So when you just push in the ring, the other ring, the one which is hidden behind comes out. Something similar happened in this particular case also. So don't do anything blindly. That is the take-home message in this. And you will have to learn to put few of the rings before you actually get hang of doing this very efficiently and without creating any problems. Here again you see one of the rings gone behind the iris. So what you do is, whatever is seen, that you pull it out and the hook comes out into the picture and gets engaged into the pupillary border. Well, removing the ring also is sometimes an issue. Initially, when we were doing this particular case, one of the very beginning case where glaucoma surgery has been done, and there is a large peripheral iridectomy, and I am just pulling out the ring, but both the arms are not getting into it, but I thought that I would be able to take it out. So I continue to retract the ring. It keeps on twirling on itself, and I thought that I almost gotten it out. At that particular point of time, the ring decides to flip, and while flipping, it goes into the peripheral iridectomy, one of the hooks. One of the hook goes into the peripheral iridectomy, and I just cannot pull it out. So what I did was, with the scissor, I cut the ring, and then twirl out the hook that is there, engage into the peripheral iridectomy, and then bring it out with the forceps. So you got to be very, very careful, and you got to be thinking on your feet when you get into trouble. And mind you, these rings also can create problems at times. What seems to be a routine case can be a difficult one. But after some learning and all, I am now being able to do this effortlessly and flawlessly, so that we can, not get into the trouble as I used to get into trouble in the earlier days. So removing the ring, what I do is that I see to it that I use a second instrument from the side port, disengage one of the hook, and then pull it out. But while you are pulling out, both the rings have to go into the thing. So choose your pupil expanding device and learn the correct technique of insertion and removal. Makes the life very, very easy. Preloaded IOL. When they came into this thing, we were very, very excited about it. But mind you, this was a case where the patient insisted I should use that preloaded IOL Clarion lens. And you see what happens, and you see how I get out of the trouble. So we put in the viscoelastic, take out whatever they tell us to do, take it out. And this was one with that gas syringe behind, and the plunger starts pushing the lens, but it goes above the lens and comes out. The lens is still inside. So I start wondering, what am I supposed to do? Because there's no standby lens, and the patient had insisted on this particular Clarion lens. So I take a gauze piece to detach the whole thing and remove it, and bring the plunger out. And there you can see the lens is still inside. So then I look around, and I can open the thing, and then the lens is sitting there. You just pick it up, put it into some other cartridge, and push it into the eye. So you need to be innovative, and you need to think what can be done, and there is always some way out. It happens with other kind of an injector system also. It's not that it happens with just one. So, this was very, very peculiar. This is the Hoya preloaded lens, and you put in the viscoelastic, and then when I took it out, when I picked it up from the box and made it vertical, the plunger just fell off. And I'll show you in a while that the plunger has just fallen off, and the lens is still inside. So there's nothing to push the lens, and again, there's no plunger because it just fell down. So again, you break open and then you put the lens in another kind of injector, and you end the day with an uneventful. So any injector can be dismantled, that is for sure. And therefore, if you get into kind of a trouble like this, you dismantle the injector and remove the lens, put it in another injector. Quite often, simple cases can also become difficult, mainly because the epinucleus doesn't come out. These are mostly the soft kind of cataracts, which you are taking it out. As you keep taking out the pieces, if you can see, the pupil is not as large as it was when you begin with. The pupil started going down. And then what happens is the epinucleus just remains there and doesn't come out. So there are, so you can retract the iris and go to the periphery, but I would not suggest you to do any of this kind of maneuvers, because as I will show you this thing, that there are simple tricks that can be done. Now here the epinucleus is not coming out, it is still there, and we are stuck. So what to do? So I was just wondering what is to be done, apart from retracting the iris and going into a dangerous area. I just came out and I realized that when I come out, the chamber shallows and the epinuclear plate just comes out. It is so simple and easy, and you can utilize this when you get into trouble with an epinucleus which is just not coming out. But best is to kind of enlarge the pupil whenever it is possible. There you will see me enlarging the pupil, and that solves all the problems. So the take-home message is, whenever the pupil becomes small, you should not proceed, but you should start thinking about enlarging the pupil by injecting epinephrine or adrenaline into the anterior chamber, and you can see how things become so simple from here on. Even you can put in a pupil dilating device at this point of time in case the pupil doesn't respond to the intracameral adrenaline. So never operate or continue to operate on a small pupil. Take a break and find out what you can do about the pupil. If you can dilate the pupil, all your problems can be solved. So pupil can be dilated at any stage of the surgery, and pupil expanders also can be used at any stage of surgery. Be prepared and not get into the trouble. So thank you very much for your kind attention.
Thank you, VC. Lovely.
Hello, yeah. So now we are left with the two legends of our time. They are the ones to follow, so we are saving the best for the last. And here is the master himself, the master of this course. He needs no introduction. Dr. Suhas Aljipurkar, Unplugged.
Thank you, Sandeep. Fix it.
Can somebody help with the AV?
Oh, there's nobody. There's nothing to fix here. Huh. Is there?
No, Coronary is the last. Coronaries were taking a beating. कोई भी मशीन खोल दे.
Yeah. हो गया? Yeah. Thank you so much, Sandeep, and my co-faculties in this instruction course. I thank you all for coming here. Thinking on your feet, I'll be showing three cases, three different interesting ones. I had to turn the course of events, my technique while the surgery was on. This case presented, as you can see, with, of course, very advanced kind of a cataract, and you can see there, obviously, in a case like this, you expect the nucleus to be very hard, and so was it. And in such cases, because cortex is all liquefied, the first thing is you try and fill it with viscoelastic. Then you also want to put an endocapsular ring right in the beginning, because you don't want the capsule to get sucked into your phaco tip. And that's the reason, look, I have not even done hydrodissection here. And I'm very gently putting my endocapsular ring in. And when you put endocapsular ring, the sign that everything is okay is that the end of the ring has to snap back into the bag. At this stage, ideally, the ring should snap back. That means the bag is intact and the endocapsular ring is proper there. But now I realize that even after the ring is placed properly into the bag, it's come out. It's a clear indication that either I have caused a false passage or there's a PCR into which the ring has gone. So that means now at this stage, I think, should I put the ring from the opposite direction? But I start seeing the lens sinking. Then I try to push it down or push it back into place, because my next strategy is I have to get the lens on top of the capsular bag and do supracapsular phaco. But it doesn't look like. So naturally, I have no time now because the nucleus is already sinking. So I change my direction. And ideally, if I have to convert it to SICS, my standard procedure is I would do a proper scleral tunnel and do it. But here there's no time because the lens is sinking. So I make a corneal incision and then inject viscoelastic. And to my horror, by the time the incision is complete, the lens has further sunk down. So what comes to my rescue is the vectis. My job is to get it and keep it on top of the rexis because my rexis is intact. And once it is on the rexis, I have time to think further, like what do I do? Now at this stage, I would want to ask the esteemed panel, Dr. VC or Sandeep, at this stage, would you still think of going ahead with phaco?
No.
Yeah, anything else would you? Because now that the lens is on the capsular bag, it's safe. Like, would you think of lens scaffolding here?
Yeah, that could be done, but the thing is that you already made a large wound.
Yeah,
You'll
yeah.
have to
So your mind is very clear to take it
Yeah,
out that way.
but in case I hadn't made a larger tunnel and just vectis had gone in and got it onto.
If your wound had not been so large, it would have been difficult for you to maneuver the vectors under the.
I know. Yeah, thank you.
Can I ask you a question here?
Yeah.
Why do you say the lens is safe on the capsule? Because the capsule is unsafe. The lens was sinking, so something has given way. The zonules have given way, and the lens is going. So you're dealing with an unsafe situation, relatively safe because it's on the capsule. But the capsule is unstable. It's broken.
The capsule is unstable for a long term. Right now, I can see my rexis circular, and it has not disfigured. So I need it just to hold the nucleus.
Yeah. But the
I get it.
zonule, why was it sinking? If
It would sink if the PC tears. See, the endocapsular ring, when I was putting, it didn't sit. That means it has caused a passage, and through that it's going down. Very often in such cases, when we have tried to put a lens in the sulcus, it has stayed there.
But Suhas,
Yeah.
you are one step away from removing the nucleus.
Yes. So, no, I was thinking in case I had not enlarged that tunnel. Like he says, if you don't enlarge, your vectis doesn't have much place for maneuvering. So now I go by the standard technique where you have viscoelastic in front of it, you have it behind, so that you can nicely, hold it and go back, and then obviously the rest of the procedure is nothing different. But I think I have put the lens. Oh yeah, and in this case, Dr. Dua, I did put the lens, a PMMA lens, in the sulcus, and it stayed there because the problem was with the capsule and not the zonules. Okay, now I had a patient who was following with me for quite some time, from as a child till she became 15 years old, and her vision gradually was dropping. It was a bilateral ectopia lentis. Every time they would come and ask, Doctor Saab, operation karegi kya? And I would tell them, as long as your near vision is good, you're a child, you're a school going kid, I will wait. And then finally she came 3 months back with vision -18 refraction with -3, and vision was 624 N10. And this is when I decided, I said I should not wait any further, and I decided to operate. Now there were multiple decisions for me to take. I have done these ectopia lentis over years, but one thing I have realized, that for such bags which are literally pulled onto one side, is it okay on my part to put an endocapsular ring, put a segment, and pull them on the opposite side and fix them? Because these are all progressive zonulopathies. So these cases, would they withstand the kind of pressure that I'll have to put to fix them on the opposite side? Well, to do it itself is a challenge. The biggest challenge in such a case, where there's a lens coloboma as well, and the lens is literally decentered to one side, is to do your rhexis, which has to be intentionally decentered, which I did manage to do. So the rhexis was almost to one side, and I had to keep some edge of that rhexis there in case I had to fix it. And in such cases, where the capsular bag is as it is small, to get the ring in and then to get a lens in, you have to be very gentle with the bag. And till your lens is in, you still have to hold on to it with your capsular hooks. These are typical capsular hooks, and very often we tend to use iris hooks, but I would advise you strongly not to go in for. The decision making is here. Now what I have done, I have put the ring, then the next decision I had to take was whether should I fix the bag with a segment. And I was very keen not to use it, because if I had to use a segment, that would be a lot of pull. So I said, let's not use a segment. If I don't use the segment and put the lens will remain kind of decentered. But then I was all the time looking at the Purkinje images. And then what I did was, what you see here, very often you have observed that after you do cataract surgery in children, the anterior capsular, anterior capsule just opacifies. So I did lot of polishing of the anterior capsule in the pupillary area. Well, what I'm doing is little controversial. And then the next step I said, I will kind of do pupilloplasty here and just try and keep the Purkinje in the center, so that the patient will have good vision. So third day when the patient comes, patient is happy that the vision is 6/9 corrected with minimal, but on the second post-op she says, doctor, vision is good, but I see double images. I see a main image and I see another image. And then I say, okay, I knew why it was happening. When I did that pupilloplasty, there was a small gap that remained. And although that gap didn't look on the table, later on, it was quite obvious. So I took that patient back again, and this was it. Meaning there was a small, tiny opening there, and that was causing her the problem. So I went back and did pupilloplasty for that. And the moment that gap was covered, her double image or the second image was gone. And with the vision that she had here, she was pretty okay and happy. Now, obviously, a question comes to everyone's mind, was it okay not to put a segment and just leave her like that? And my explanation, I may be wrong, the panelists can always correct me. If, let's say, if at some stage, a few years later, I realize that no, over a period, the bag is, kind of decentering quite a bit, I still have an intact bag so that I can go with the newer segments that come and fix the bag. But for the time being, for as long as she enjoys good vision, I thought I will not disturb it. Would anyone like to add on?
I've seen these capsules fibrose very quickly,
So the exposed capsule in the pupillary area, I have polished it.
Yeah.
And let's say the bag doesn't decenter, but the capsule, opacifies. I can always make a small nick, but that will be risky because if I nick it, the future possibility of fixing the bag goes away.
And does the posterior capsule also not opacify?
See, posterior capsule can opacify any time, it will opacify. I can always do yak capsule, that is not my concern. My concern is if I can retain the anterior capsular rim, I still keep a possibility for fixing it at a later date in case it gets.
It will be interesting to see how this lens behaves over a period of time.
Yes.
Because you have fixed the back to the equator. So
I have not fixed the back.
oh no, okay, you just put a ring.
I have just put a ring and I have done a pupilloplasty so that,
Well, Dr. Dua can comment about that.
The only thing going through my mind is this is a zonulopathy, as you said in the beginning, and the zonules are going to continue to weaken. It's a young patient. Over time, the whole capsule, not just one segment, can pose a problem. And you might find that the lens with the capsule is sinking or dislocating because of the zonular problem. Then you have a bigger problem at hand.
But I would like to share, see, I've been practicing for the last 45 years. I have done many ectopia lentis and quite a few pseudo exfoliations. And most of the pseudo exfoliation will come, but I'm yet to see an ectopia lentis, even after 20 years, coming back with a lens bag complex dropping down. They don't drop down.
I've done aniridia patients with cataract and then put an aniridia lens in the bag. And many of them, not many, but at least 3 or 4 of them have come with the whole capsular lens in the vitreous. And I've seen this referred to me in other cases that have come as well. Then you have to fish out all of that and do a scleral sutured lens in those patients. So maybe the pathology is different in these.
Now this we have seen all the time with pseudo exfoliations. So VC, do you remember seeing any of these ectopia coming years later with bag lens complex?
Exfoliation, yes, but not
Yes,
the ectopia. But I think in your case, the pupilloplasty is going to help the patient for a long time.
Yeah, that's
so
right.
a little bit of decentralization.
I'm prepared, I felt, for next 10 years of a good vision because the technology keeps changing. You can always go and redo it.
I have one question for you, Suhas, is many of these ectopia lenses I've seen, post-operatively years later, they have many vitreoretinal pathologies, including RDs happening. So does the pupilloplasty restrict the view of the fundus?
Pupilloplasty today is to give him better quality of vision. Tomorrow, if I do not want it, tomorrow I want to do VR intervention, I just have to put YAG. And the reason I did this was, let's say the only other option for me, if I didn't want to put a segment, was to remove that bag and fix a lens. That means I'm already entering into that posterior area. And here, you're not done vitrectomy, you're not entered into posterior segment, and still patient is 6/9, enjoying the vision. And I'm sure he'll enjoy for another 10 years.
My other thing which I do sometimes, which I have now realized for ectopial lenses, is I always put the lens in the sulcus and then capture it under the anterior capsule.
Okay.
Because, I think the sulcus is a rather safe way to put the lens, and it avoids decentration, which will happen when your lens is in the bag with a progressive zonulopathy.
For that, yes, but for this, where the lens is already shifted up, the bag is already shifted up, putting it into the 3-piece into the sulcus and fixing it, the lens would also go up. But anyway, that's a good point. We have time, no? No, okay. So with this, I end my talk, and it's my honor. It's a double honor. One, that we had international celebrity attending our instruction course, sir. And today, we are privileged to have you. I invite you here, sir, to deliver your keynote address.
Leftist बोलेगा तो ट्रम्प और
Well, good afternoon, everybody, and thank you very much, Dr. Haldipurkar, other members of the panel. I have already learned a lot more than I can teach today, so thank you very much. And a good amount of my talk and some of the salient points have already been covered and demonstrated in the videos you have seen. And just to re-emphasize some of those, in iatrogenic iris trauma causes and consequences. So let's start at the beginning. What makes the iris vulnerable to trauma? The iris is very thin right at the root, at the periphery here. So that's where it tears very easily, and we have seen that in this picture shown before of iridodialysis, which happens with iris root tears. It is also a very vascular structure, and it bleeds quite easily, and you can get a lot of bleeding from the iris root. You can get a bleeding from the pupillary margin, where often there are little tufts of vessels. You can see them on the slit lamp and anticipate this problem, but often they are missed. They are fairly common to see, and they can be as part of the normal structure or as part of some disease process in the past, as we see over here in this iris angiogram. And even the fact that if you have a perforation with the iris over there, you can get vessels from the iris growing into the cornea in a centrifugal direction. So it shows you how vascular the iris is. The iris structure is made up of mesoderm and the pigment epithelium. The pigment epithelium is very easily disturbed, and as it comes out and with your manipulations, you get this transilluminant areas of the iris because of the trauma of surgery. You get pigment dispersion with pigment collecting on the lens, which can cause glare and halos on the iris and also in the angle, causing glaucoma. The lens gives good support to the iris. If the lens is not there, the iris flaps around, and a floppy iris like that can be easily sucked into instruments or prolapse from the anterior chamber. That makes it a little more vulnerable. And then when you do anything to the iris, as we have seen, even a dilating device, stretching, cutting, or as in this case, stitching, you get prostaglandin release. Prostaglandins are the common cause or the culprit for cystoid macular edema. So when you have manipulated the iris, think about the possibility of cystoid and give a prophylactic course of steroids to these patients, increase the topical dose that you may normally give, or consider a short course of oral steroids. Now, what are the risk factors for iris complications? We've seen a small pupil, shallow anterior chamber, floppy iris, patients on tamsulosin, and a large wound, not well constructed wound, high irrigation pressure, and positive pressure due to choroidal vasodilation. If you suddenly lower the aqueous, release the aqueous, and there is sudden collapse of the anterior chamber, sudden hypotonia, you get choroidal vasodilation, and that can cause the positive pressure on the back of the eye. Now, when you see something like this, and we've seen this repeatedly today, the iris coming out, it is primarily due to increased pressure in the eye and due to a poorly constructed wound. The last thing you want to do is use some kind of a hook instrument to push it back in. And I will illustrate that in this video kindly lent to me by Sadir Hanush, a corneal surgeon, and he is doing DMEC, phaco-DMEC, so the lens is put in, everything is okay. The DMEC scroll is injected into the eye, and as he's taking it out, because of he's releasing the pressure, but this prolapses out. Now, as you try to push it in, like you do with the iris, you try to push it in, the hook will catch on the iris root will have a small tear, you get bleeding, and there's blood all over in the anterior chamber. So you've caused iris trauma and made life very difficult. In this case, the blood was sucked out, all that, and a little extra time, and the operation was successful. But instead of trying to push it back, release the pressure in the eye and tap it back with a blunt instrument. Just tap over here on the cornea. If the pressure is not high, the iris will go back in. Now, the other risk factors, of course, vitreous loss, and if vitreous loss is not properly managed and there is vitreous in the wound, then the whole iris gets pulled to that side. The proximity of all the instruments you're using to the iris makes it more a high risk of damage, and as you can see over here, the patient's visual outcome will be poor because the edge of the optic is visible in the pupillary area. And then head movements. Now, this happens rarely, but when it happens, it can be a problem. This routine cataract operation going, and suddenly, it's not the camera that is shaking, the patient has made a movement. Now, this was one of our residents who was recording this. Fortunately, he managed it very well. But you can see the iris trauma and even the corneal trauma. And see, when the iris is damaged, that floppy iris wants to come straight into your suction device. So you have to bear that in mind, put extra viscoelastic while you're taking the cortex out and try and avoid that. But here, the outcome was successful, but notice the little posterior corneal trauma as well as the iris trauma caused by the sudden head movements. Now, these are, of course, well-described risk factors, and we've seen many of these previous iris disease, small pupil, stuck pupil, and when you try to enlarge the pupil by whatever means, you're going to cause iris damage. Even while releasing synechia, you're causing some iris damage. Here is a patient where we had a cornea graft with cataract and a very fibrous capsule, and we are using the stretching. I use the Hirschberg hooks to stretch the pupil, and that is causing tears, minute tears, or at least rips in the pupillar sphincter muscle, and that is a kind of trauma which I was alluding to earlier, will release a lot of prostaglandin and will cause problems later on if in some patients with cystoid macular edema. And all of these are causes or risk factors for iris trauma, and the way in which the iris is damaged by the prolapse, aspirated into the instruments. So many times you've seen chaffing and the phaco probe catching the iris and taking bits away, iris root stairs, etc. Now, this was one example again where the lens had opacified, and the opacified lens is being explanted from the eye, and you can see the video over here, what happens. All these maneuvers in the eye to try to take out a calcified lens, often you have to cut the lens and take it out, but as you're explanting it from the bag and trying to bring it into the anterior, on the anterior capsule or anterior to the iris, you can see it digs into the iris roots and causes tears and a lot of bleeding. So that what is to be avoided or kept to the minimum to avoid damage. Here again, the iris has been caught in the lens, and clearly you've got problems with the lens being in the anterior chamber and causing corneal as well as iris problems. These are some examples of iatrogenic trauma, and you can see the iris can be quite distorted by even malpositioned, malfixated lens, subluxated iris claw lenses, etc. And this is an old Sputnik lens that is dislocated and causing trauma to the iris. So what happens when you get iris trauma and the pupil distortion? You get all these symptoms: glares, halos, dysphotopsia, uniocular diplopia, quality of vision is poor, cosmetically it may not be good for the patient, and you eventually have a very unhappy patient. So how do we deal with these traumas? You have to look at these 5 considerations. First is the optical, the shape, size, location of the pupil. Is that okay, and how can you get that back right? And at the same time, visualization of the retina. The question was raised, will it be good enough to see the retina if you want to in the future? Structural, if you're dealing with healthy iris tissue and dealing with atrophic iris tissue, the strategy to manipulate that will be different, because atrophic iris tissue is not as elastic, doesn't stretch, and when you try to approximate, it will tear, or the sutures will cheese wire through it, causing more damage rather than fixing the problem. And then functional, does it address the patient's visual symptoms, which are of course the biggest concern for the patient? Cosmetic, obviously you want to give the patient a good outcome, because some of them are more bothered by the cosmetic appearance rather than by the vision, and you will see patients who want it to look better rather than to see better. So that is their wish, and you have to bear that in mind. And expectational, so you have to inform the patient of all the pros and cons of what might get worse when you're trying to make it better, complications, etc., and that the cosmetic result may not be guaranteed. So you can do these measures preoperatively by preventing iris damage, so mainly pharmacological, and we've heard that stop all miotic alpha, be aware of patients on alpha blockers, pseudoexfoliation, some of them on the non-steroidal anti-inflammatory drugs. We stop those because of the fear of melts, etc., and give them mydriatics or preoperative steroids if they've got iris inflammation in the past. Herpetic eye disease, herpetic zoster, and simplex patients will have a lot of iris transillumination, and when you see that, then it's worthwhile covering them with antivirals preoperatively and carrying them postoperatively with oral acyclovir or ganciclovir. Intraoperatively, we've seen all the maneuvers people have done, and they're all just listed over here. We've heard them, we've seen good examples how to prevent iris trauma. And again, to show you this little video here where we are doing corneal graft with a lens extraction implant, the same patient with an atrophic. So releasing synechiae are going to cause peripheral iris tears or holes, which we have to stitch separately. You release this synechiae, you stretch, and in this case, we're going to do a lens extraction after a capsulorhexis. So again, the Maillugin ring, as we've seen, comes to use, and you always use vision blue even if you're doing open sky, and keep the pressure low to prevent further damage to the iris. And then the repair process, you can decide whether you want to do it at the time of the operation when the damage happens or subsequently. If you do it intraoperatively, the patient doesn't need a second operation and doesn't need the unhappiness or the dissatisfaction of coming out of the operation and saying, I've got a problem, it needs to be fixed again. If you've done it all together at the same time, at least you told them there was a problem which has been fixed. And the sutures are very, very useful, as we've seen again in damaging iris repair. And it depends on where the iris is damaged, the potential effect on the vision, and how you will suture them back into place. And there are different ways in which you can suture the iris. And you can do the same thing post-operatively, either repair the iris or counter the effects of the iris pigmentation by doing other things. As we see over here, you release the vitreous and you suture it in place, or you use these prosthetic devices, and there are a variety of these devices. Unfortunately, they've stopped making these kinds of aniridia lenses, but you can use this human optics aniridia lens, insert it, and to then address the damage. Like here, there's total loss of iris, so clearly there is no iris to repair, and you have to use one of these prosthetic devices which come in different colors, and here a brown one has been inserted in this eye, and that was the human optics lens. So that's the summary, or the points have already been made in these eloquent presentations by the speakers on cataract surgery, and one has to prevent it by making sure you're working with a dilated pupil preoperatively, and if it happens, damage it, repair it during or after the operation. Thank you.
Thank you so much, Dr. Harminder. That was a wonderful presentation. Just a small, question, like for the audience. When you have a patient who's under treatment for herpetic keratitis, and eventually he comes for cataract surgery, what will be your standard protocol with regards to his medications?
So if the patient has been quiescent for a long time, then you give 400 milligrams twice a day of acyclovir, and you start that at least 1 or 2 weeks before the operation, and carry it on for a long time till all inflammation has settled, for two reasons. One is that your stress of the operation can trigger the virus activation, and secondly, because you're going to use steroids in these patients post-operatively, you increase the chance of any reactivation to become florid infection. So to counter the effect of your steroid use, you will probably you will be helped if you use oral
That
acyclovir.
long time could be for a month or more?
Yeah, so if the patient is already on acyclovir prophylaxis, so somebody who's got repeated episodes of herpetic eye disease, we put them on at least for 1.5 years, 400 milligrams twice a day of antiviral, acyclovir that is, and then during that you can do the operation anytime. But if you're, and then the steroids use will be covered.
Thank you. Audience, if you have any questions related to the topics that were discussed today, you're most welcome to ask. Otherwise, you have been a wonderful audience. I thank all our friends and panelists, the co-instructors, for conducting such a wonderful instruction course. Yes, please go ahead, sir.
Sir, I have a question. Sir, if you don't know that is a viral disease in the cornea, suppose you don't know and you operate for the cataract, and post-op there is an epithelial disease, how to manage it?
What you can do, you start topical acyclovir or ganciclovir 5 times a day, just like you would manage a patient who had not had cataract. You will do the same. But the question here is, what do you do with the steroids?
Yes.
So what one could do is not use steroids, but switch to something like cyclosporin drops, where they are more specific, they're not as much risk of activating the virus or keeping the virus going than steroids would be. So you can use acyclovir, you can use Icurvis that we have, cyclosporin. Here you have Sequa as well, so from Sun Pharma. So cyclosporin drops, or if you have tacrolimus drops, you can use that as well, and it will be less risky for the virus activation compared to steroids.
Sir, can we use oral steroids?
You can use oral steroids, but oral steroids will also increase the risk to some extent, not as much as topical. Yeah.
Excuse me, Dr. Haldipurkar.
Yeah.
Can you tell me the advantage of bevel down phaco tip?
Bevel down, oh yeah. Well, bevel down easily kind of cuts down on the phaco energy directed upwards. Okay. Now, if I have a patient whose endothelium not very healthy, my attempt would be to do more of bevel down phaco. Now, the only problem with bevel down phaco is you are closer to the posterior capsule. But then with your newer parameters, with bevel down, you can still stay away from the posterior capsule, and be more effective as well. So my practice is bevel down or bevel sideways, because that way your efficiency to purchase on the nucleus becomes higher.
So in all cases you go bevel down or only hard cataracts?
In most of the cases, some steps I would go bevel. In hard cataract, like the one that you saw, when you go bevel down, you get a much better purchase quickly.
Thank you.
Sometimes at the bubbles, every time you try to get their chop, there are bubbles coming up. So I think that kind of reduces if you make the bevel slightly, oblique, not maybe directly pull the bevel down, but that oblique definitely helps.
Thank you.
Thank you. Thank you so much. Can we have a picture with us? Yeah. आगे चलिए.
जनपद में तो मिलता है